And then most importantly for us, when we talk about technical skills, but it's also the non-technical skills that happen, both outside and inside the operating room. And so those being kind of your situational awareness, your decision making, your communication with your team members as well as other consultants, and then especially for the senior residents as they're growing into attending, developing that leadership, taking ownership of the patient, making those hard decisions. So kind of the other intangibles outside of the operating room. And so when we look at a literature review, specifically this first paper talking about defining the autonomy gap, uh, you, the conclusions from the paper were that, you know, when you were talking about operative autonomy, both faculty and residents felt that they had a similar expectation about the residents' autonomy. But when they talked kind of performance wise between the resident and the faculty, it was felt that the residents kind of failed to achieve that shared expectation that was discussed prior to. And so this paper kind of concluded that there's an autonomy gap, and more evidence needs to be in terms of preparing residents for independent practice. This is another paper, again, kind of talking about the perception of autonomy in the operating room, and had kind of similar um, findings. And that both the residents and the attending felt that there was a perceived amount of autonomy, but when it looked at the actual um, how much that they performed, that there was an actual gap between what the trainee perceived and what the attending perceived. And so then, coming into briefing, one of the things is called the educational timeout. And here's a paper that actually looked at the effect of educational timeout in resident education. And so this was kind of the little slice from the educational timeout. What step of the operation do I want to focus on? What is my current level of competence, and what techniques or strategies should I use to reach that competence level? And then when they looked at the results, uh, you know, they saw that the residents reported that there was an increased goal setting, after the intervention, and that um, it was a positive impact, and that they felt that the educational timeout identified deficits, allowed them to increase autonomy and increase feedback. And so both residents and attendings agreed that this was a good experience. And so then when we get into debriefing, so when we get into debriefing, this is one of the most actual important aspects of learning. It allows both the resident and attending to kind of reflect on what just had taken place, and reflect on what went well, what didn't go as perceived to as well, and what things that you can do to improve upon, and clarify knowledge gaps. Um, it helps facilitate adult learning, self efficiency, and self evaluation, and provide some onus of responsibility on the learner themselves. And in doing so, the learners learn to work on their own knowledge. They get self awareness. They learn to promote transferring of the learning, and then ultimately can also share a mental model with faculty. And so, most importantly, research has shown that these learner-centered, or both resident-driven along with attending interaction, promotes an increased, learner experience compared to just an instructor-led course. And so, two of the kind of most important aspects when we look at an actual debriefing is a an environment of psychological safety. So it's very important that the residents and know that it's a safe environment for them, where the attending is there trying to improve upon both their skills inside the operating room as well as outside. And it's not meant to be a negative experience. It's supposed to be a positive experience. And so when we look at debriefing, you can see there's a whole list of forms. And they talk about, you can go through training models of learning how to debrief. I think most importantly for the attendings, when you talk about debriefing, it's really finding one of these strategies that work really well for you, and then sticking in and improving upon it. And so this is the most recent study, looking at a systematic review of a bunch of studies, through Medline, PubMed, looking at studies that did a preoperative briefing and debriefing, and ultimately basically found about 17 studies that were worthwhile to look at. And then in terms of when they identify measures, there's this Kirkpatrick model of learning. They identified 12 measures from there that they analyzed. And so here's those studies right there, and it spans across the fields from general surgery to OB to orthopedics, neurosurgery, all looking at briefing and debriefing. And so when they looked at those Kirkpatrick models, they found that a total of 95% or 95 of them were identified, and of those 95, 93 of them had significant benefits. So when they broke it down into kind of four Kirkpatrick categories: reaction, learning, behavior, and results. In the behavior portion, 7 of the 7 studies investigating reaction were positive, and 11 of the 13 studies examining learning were also positive. And then 12 of the 14 studies looking at benefit were investigating behavior were positive, and 6 of the 9 looking at surgical results were positive. Only 2 of the 15 studies had a single statistically significant detrimental result. And so from this, they kind of hypothesized or came up with what they call a framework for debriefing and briefing that they recommended for use. And so some questions for the residents before I get back to the presentation, but by a show of hands, how many of you guys review the patient's chart and kind of pertinent imaging the night before a case? And then who rehearses the operative steps of the procedure prior to the operation? Who makes contact with the attending before the case to discuss the case? Who with the attending? Who discusses what portions of the case they'd like to focus on? So we have a proposed study. Our IRB GME approved to work on a debriefing and briefing study here with you guys, the residents and attendings. And so again, getting back to it, training autonomy has sharply declined over the past 2 decades, resulting in reduced preparedness for independent practice. And so it's critically important to maximize, educational learning. And so, and that way it reduces burnout and increases technical skill acquisition. And so, just as stated, the importance of a debriefing and a briefing, it's important to really use those times to also promote learning, and not just in the operating room. And so, despite all of this knowledge, they actually say that a preoperative debriefing often is unstructured or is completely neglected, even though we know the importance of this information. And so, like I said, we have an IRB and approved by the GME. And so the purpose of this study is to improve resident self-awareness, autonomy in the operating room, and kind of standardize feedback for the attending surgeons. And so, most importantly, as we talked about, in the debriefing, you have to promote in a state of psychological safety. And so when we're going to do this, we really need 100% buy-in from the residents and staff. The residents preparing for the cases, and the staff providing meaningful feedback at the end of the cases. And so for you guys, shortly in the coming week or so, you'll get an anonymous survey that you'll come to your email. You'll fill it out, allow us to get information that we'll talk about. Just some demographics, asking you some learning styles. This may work better for certain learners, and then talking to you about how you approach, a case, and asking you a little bit about what forms of feedback you get after a case. And so for the briefing portion, residents will be asked to prepare for the case, reviewing the chart, paying particular attention to comorbidities, patient's unique anatomy for the certain operation, and then reviewing the operative steps of the proposed operation, understanding the procedural steps and identifying potential pitfalls. And ideally, this will take place at the scrub sink, but we'll send at the scrub sink will be a briefing and debriefing sheet, and I'll send that to you as well. So this can happen anywhere. You can pull it up on your phone, and each of these sheets are supposed to be kind of guides or whatnot to basically to complete these briefings and debriefings. And so the briefing will kind of look like this. So it'll have 4 categories: the goal setting, and so you guys will go over these in particular. Each one. What portion of the operation would you like to focus on? What are the residents' goals for the operation? The resident actually discusses the goals and objectives, and the attending says, "Are these appropriate?" And then looking at autonomy and experience, what is the resident's level with the procedure? And then looking at the Zweig scale over to the right of the screen is, what is their anticipated level of autonomy? And then in terms of the preparation, discussing the pertinent history and imaging on the patient. Are there any aspects of the patient's anatomy that pose a challenge to the operation? Talking about specific instruments, positioning, anesthesia needed for the case. And then lastly, discussing the key steps of the case, and discussing, each the residents and attending roles in the case, and then what tactics are going to be used for attainment of those learning goals and autonomy. And then the debriefing. This will take place hopefully within 24 hours of the operation, but ideally directly after the operation. Both the resident and attending will be asked to review the debriefing card. And again, it will have, those same 4 categories. In goal review, did the resident achieve those learning goals? And if they did or didn't, reflecting on why it was achieved or not achieved. When we look at the autonomy, did the resident achieve the anticipated level of autonomy per the Zweig scale, and reflect why that level of autonomy was not achieved? And then self-awareness, does the resident actually understand their true level of autonomy? And then when we talk about performance, evaluation of the resident's technical skills in context of case complexity, and then evaluation of those non-technical skills. And then lastly, in terms of strategy review, what went well, what can be improved upon, what can we apply for future cases? And then ultimately, once, this will last for about a month or 2 is the anticipated time to collect data. Then we'll have a pre-intervention study or a post-intervention study. Again, anonymous, collecting data. It'll be similar to the pre-intervention study, and so based on that, we'll analyze that data, and if the findings are positive, then this may be something that we do on a regular basis for your guys' learning. Any questions?
Is this going to be for every rotation or just your guys's?
No, the plan would be for every rotation, mostly the general surgery, so that you guys get a lot of contact.
He's handing it to me. Thank you. I think a lot of these things in my mind, I always think are basic, Like, did you read the chart the night before the operation? Like, I looked, I didn't see every hand go up. I was like, I do. But despite that, uh, the point in the presentation where you say adjust to a realistic level of autonomy, I think that could be very tricky. Can you give me some tips on how, when I'm having this very short 2 to 3 minute interaction with a resident, um, that I can realign their goals with like a realistic goal?
Yeah, I think obviously one of the questions asked is how often have they performed this procedure? Getting an idea, have they done this once or have they done this multiple times? Asking them, what portions of the procedure do you feel like you do well? What portions of the procedure do you feel like you can improve upon? I think most importantly, the paradigm of needing to do from skin to skin is unrealistic. If we're going to get improvement, the idea would be focusing on certain sections of the case that residents need to improve upon, and that way attendings can give them actually more time to struggle and actually learn in that case, instead of this concern that that portion will get taken away from them. So I think it will, and then again, after the case, discussing actually with them, I felt like that went well. I do feel that you do this portion well. You're at the appropriate level of autonomy that we talked about, or and I think that you should move on to another portion of the case that work better, or I still think we need to work on that portion of the case. You know,
Great presentation, Dr. Clark. There's a slide you had, the one about the whether the residents reviewed the charts the night before. I wanted to bring a situation up, which probably needs to be
is there a
reviewed.
question?
Yes, there's a slide with,
Yeah, did I ask them?
yes. So recently we had a patient one trauma patient, needed a PEG. All through TBI, mainly TBI, but all through the week, oh, we're gonna do a PEG, we're gonna do a PEG, we're gonna do a PEG. And the PEG was scheduled for Friday. Everyone has reviewed the chart. And so morning of the procedure, the consent wasn't done. So got consent that morning, took patient down to OR. And so I walked in the OR, patient's already intubated. Figure out that there's no resident in this case, I'm just the one. So I called my core attending, say, hey, I think I'm gonna need help with this PEG. And then I examined the belly, and he has 2 large transverse scars across his belly. And I'm like, I went and sat down the chart and started digging. It's not in, the charts we've been doing. He's had a pancreatectomy, he's had a colectomy. So I called my colleague, so I had to call his son on the phone. Patient's already under general anesthesia. I called his son on the phone and say, well, I saw this big scar and we didn't know about this surgery. And we're going to do this laparoscopic assisted. So got a consent for laparoscopic assisted endoscopic gastrostomy. And we put this camera in, and this whole entire abdominal contents is plastered to anterior abdominal. I could even visualize the stomach or the intent or the liver. The whole upper quadrant was just plastered, omentum, mesocolon. And so at that point, we call back the son and say, well, this is going to involve a way bigger operation than like an open operation. And patient was awake, GCS 15 prior to this operation. I don't think this is something we should go digging through, opening him up and all that without at least having a discussion. So that's where we're aborted the procedure. So my whole point of this conversation is, as a resident and as an attending, I guess I've gotten spoiled by the present PGY5 class. Because, you know, you have Sebastian and Kyle, they would go through the entire imaging and tell you this is where we need to go in from. And, you know, so I think over time you just get spoiled and, you know, not do the due diligence before for the case of the residents. I think you should, and I'm sure a lot of fifth years do it, but for the junior residents, you should learn from those guys how to prepare for the case, review the chart, look at the pertinent images the night before, at least before entering the room. This is on me because I should have done that, you know, because my mind is a routine peg, you know. So this is a truly important aspect of care that we shouldn't overlook.
What was the handoff for you to take over that case though? Were you like just made aware of it that morning, or like where's the like miscommunication there from like attending to attending?
No, there was no miscommunication. It was by me. But what I'm saying is, what I didn't even know there was not going to be a resident that day. And we go through this, you know, we round every day. Nobody actually touches the belly. Patient's doing okay, TBI, you know. So typically, if I get a consult for a peg tube, I go look at the belly and look at it myself and say, okay, and the questions I usually ask, any previous abdominal operations, and then I look at the CT and things like that. But in this patient who's been on the service for a month, 30 days on our service, it's a trauma service, so you just kind of assume all this has been taken care of beforehand. But so it's actually on me.
That whole scenario, when I listen to it, it makes me think about a couple of things. Number one, the old adage that I grew up with in residency, which is trust no one, assume nothing, sabotage is everywhere. And you can sabotage yourself. But that being said, the balance between responsibility for the patient, medical legal risk, and autonomy. Can you talk a little bit about how in an environment where we're bringing up how fast we do something, how safely we do something, how many complications we have, how to share that responsibility, and ultimately, like, we're the ones being graded or judged or sued for the problems that we have on that side?
Yeah, I think it's important, exactly, in this day and age where, you know, 5 cases are on the board, and attendants don't have the time to stay till 10 p.m. to get 5 cases done. You know, that's where this comes into play, talking about what portion of the case are you weak in that you want to work on. And the expectation would be that attendings allow residents to struggle during that portion and provide oversight. But it's fair for, you know, portions of the case that the resident is already competent on for the attending to speed through if they need be to advance the case, right? Because if you're competent in that portion of the case, you don't need to do that portion of the case again. And actually, if you're competent in that portion of the case, you know, as a fellow, once I was stronger in portions of the case, you actually pick up things that the attending is doing that you're like, oh, wow, that's why they're faster than I am. So there is an importance. So, you know, a lot of people use the excuse, you can learn a lot by watching. If you are a novice to that portion of the case, no, you're not going to pick up on that stuff. But once you have become competent in those portions of the case, you can learn a lot from actually watching. You can learn how attendings, you know, get through a case because, you know, there's no wasted movements and things of that nature. And so I think that's where that comes into play, talking about the attendings allowing residents to struggle at those portions of the case that they need to get better, but portions of the case that they're facile and that if cases need to get done, then you know, the residents can push, or I mean the attendings can push through that portion of the case if there needs to be sped up.
I try to be as concise as possible. One of your earlier slides said that autonomy has been diminishing over the last 2 decades, and I don't know if you have an explanation for that. And then I have a second question, what I'll get to in a second. But I'll preface that by saying, you know, I started my surgical training 36 years ago, and when I was a resident, I did 2 appies and I was expected to do them on my own without anybody present. And I also, 30% of my cases and attending was never present for my entire residency. So autonomy was sort of given and it was expected, because if you didn't, then the patients would suffer. And then the other thing I'll add to that is that, I've been part of 4 residency programs since I've been a surgeon. 2 were military, 2 were civilian. The distinct difference between the military residencies and the civilian residencies is that at the military residencies, the expectations of the residents and the trainees is that you're going to be capable of doing everything on your own with no support whatsoever day one, the day you graduate. And therefore, we reflected the autonomy to give them the authority to do things on their own. We did it quite a bit differently than what CMS allowed, but we had a waiver for that because the military allowed that because of the expectation to deploy. Is it therefore our error as educators that this in the CMS rules that our autonomy is diminished as trainees? Because it was different when I was a resident, and it's definitely different for the military trainees.
Well, I think we're learning more of it's not just what happens inside the operating room, but it's what happens outside of the operating room. Because where I trained for general surgery as a chief, I was taking first years through all the cases, and none of the attendings were in the room. But when a chief is giving feedback, who's not an exceptional an attending at that case, the feedback is different from someone that has done it year in and year out and everything like that. And so it is a failure in terms of the teaching, because you need someone that is an expert, not someone that is advanced at the procedure, giving the feedback, guiding the resident, teaching them where that they can do better to advance that case and everything like that. I definitely noticed that from general surgery training to fellowship training, where yes, as a chief, I was giving the advice or getting the advice from chiefs and rarely getting it from attendings. And then in fellowship, having an attending actually break down where I could improve in the procedure and whatnot.
And then a follow-up question related to your study, which I think is a great idea. Are you planning on how is it structured? Are you going to have like a champion for your study for each one of the divisions so that we can therefore be more compliant with what the expectations of the study are in terms of how we do the debriefs and the scoring and all those other things, associated with meetings, so that we can make sure that we're accurately complying with the goals of your study?
Yeah, as I was kind of preparing for this, I had discussions about that, and I think if you guys are willing to, yeah, I think that would be absolutely great. I was gonna ask for create slides at these presentations to remind attendings and residents to continue to be doing the thing. But I think a champion in each division would be great. I just didn't as well want to burden faculty with it and stuff. So, but I think compliance wise, it would definitely improve compliance with this and give us a realistic when we analyze the data if this is something beneficial for this program or not.
Okay. I have a couple of comments. Number one, I feel like the main point of this, right, is making implicit things explicit.
Yeah.
Right at the heart of all of this is good old communication, understanding where you're at as a trainee, and understanding how willing your attending is to let you do XYZ things during the case. And I see this as a tool to help aid that communication, just like simple, right? It's a way to give us language to communicate about what you are prepared to do as part of an operation and prepared to do to take care of patients. And it allows us to be open about those expectations. I think this is going to be a great addition to our use of Simple, which we are still working on bolstering that experience, right? Using Simple as a tool. There are obviously lots of barriers to making this happen, right? Because we can talk all day about how we need to improve communication. Can you give us a couple of recommendations on how we navigate some of the barriers to making this the most effective and helpful tool possible?
My hopes is that each of those 2 slides for briefing are on laminated cards, and so those will go at each scrub sync, as well as me sending them out to you guys so that you have it. And the hopes is that would at least initially be kind of a structured conversation that is had between staff and resident, to guide that. And then as everyone becomes more comfortable with it, it just kind of flows before and after the operation.
Great. I would also see this as a mutual responsibility, right? It's equally, the onus is equally on faculty as it is on trainees, right? Our ultimate goal is the same. It's shared to take care of patients, but we each have a role to play as part of this. So looking forward to using this tool.
So a couple of comments to Dr. Sincere's point. There have been several landmark cases that relate to medical legal consequences of attendings not being present in rooms. One of the biggest was a orthopedic case at MGH where the attending surgeon was not present for what was considered the most important. Two more recent cases involve cardiac surgery attendings in Texas for the same reason. So autonomy is definitely different than what it used to be. The second is that next question, which was how do we do this? Not a terribly new concept. Back in the 2000s, I won't say which year because I don't want to date myself too much, but the basic requirement of my thoracic attending was that before you did any case, you wrote the patient's history on the whiteboard in the room, your version of the patient's history. So you knew everything about the patient's history and you would document that you knew it. You would also write the 5 steps that he thought were the most critical steps in the case, and he would come in and basically discuss the history and which of those steps you were going to be responsible for. So it worked very well, and this is essentially the same concept, the same framework. And afterwards, he would tell you whether you could move on to the next step or not, basically, and the why. During the case, if he thought you were doing well, he might actually let you move on to a different step. But again, if you weren't, you were stuck on step 1, 2, whichever one it was. So again, I think this is a very useful tool, and it will help you as residents move forward. But it also helps the attendings. It'll avoid the issues of showing up in a room not knowing there was an incision made where you were planning on working.
I think you alluded to this a little bit, in terms of like the value of having an expert watch you do something. I think a lot of this framework seems to involve kind of co-creation, right? So the resident is telling you, like, here's what I've noticed I need to improve on. And I think that, my observation is that that's something that a senior resident or a chief resident is able to reflect on and do. But a novice learner, they don't know what they don't know. So how do you guide them in identifying a realistic learning objective for a case that they've never seen or done before?
Yeah, I mean, I think, you start with the basic portions of the case, and so getting through those portions of the case first, especially if they haven't done them, and then going from there. But I think, it becomes even simpler of, maybe it's, they're not going to want to hear this, but, you showing them that portion of the case. You talk about what portion, you talk about this is how I do it. Because for the novice learner as well, they have exactly no framework. So and this is kind of part of what residency and fellowship is that you start following kind of or learning people's way they do something, and then as you become more advanced at it, then you start developing your own technique of way to do it and all that. So just being a very succinct and as an attending describing, in immense detail to those novices that this is how I do it, this is why I do it, and everything like that, and then obviously, and then that way they understand, and then hopefully as they do the next one with you, they understand why you do things, and they do those things and can repeat it and and build confidence with you and continue to do more.
And just another question, so what happens or what strategies or advice do you have for us when you are doing an operation and, for example, in acute care surgery, oftentimes you don't know what you're going to find, right? It's free air, but who knows what it's from. And so you have a debrief and maybe it may be difficult to identify like what you're going to work on because you don't know what the operation is, or something unexpected happens. The patient has incredibly dense adhesions or it's not safe. How do you, pivot so that there's still you know, you're still kind of taking advantage of that preoperative timeout, you know, or what strategies do you have to have with that disconcordance between what we said we were going to do and what we ended up finding?
I think in those cases, you know, it's just a good teaching experience. So maybe, like I said, if you don't know what you're going to get into, maybe running a case scenario through, like, hey, if we get in there and we see this, what are you going to do? And then I think, you know, when it comes to discussing at the end, or even mid case, you know, if something happens and you have to take it away, you know, you say that, like, hey, I didn't expect that this was going to happen. I promise I'll give it back to you once, you know, things have, you know, calmed down. You know, but right now, you know, it's a dire strait, and so and then I think after the debriefing again, it depends what the resident gets to do. So if unfortunately they're not able to do a lot, I think again that's another instance where you can, you know, discuss example cases. You know, say this happened. You know, what are you going to do here? What you know, what technique would you use to do this, and whatnot.
All right. Any other questions? All right. Well, thank you, Dr. Clark. We'll look
Thank you.
forward to this. I'll make another plug for using this in combination with, you know, simple and EPAs. I think you can do them right at the same time. You know, the Joy skill, if you forget what it is, it'll be right there in the EPA app, and you can give your feedback, and you have the structured framework to do it, which sometimes I know you know, get to the end of the case and I'm like, what comments do I have? And I'm like, you know, what Nevada, you know, can't remember. So I think it is very helpful to have a structure to kind of remind you to hit those critical points. So thanks again.
Thank you.